Dr. Renee Quarterman is a board certified and award-winning breast surgeon. She graduated from Brown University and Duke University School of Medicine, completing her surgical residency at Oregon Health Sciences University. With more than 16 years of professional experience, Dr. Quarterman has created and grown successful breast surgery practices across the country. She served as medical director for several breast centers, overseeing all aspects of breast health. She maintains an active presence in the medical community and works tirelessly to promote awareness of women's health issues. She's also served as a founding contributor and editor of breast360.org. Notable organizations have honored her many contributions, which include the Recognition of Excellence from the American Cancer Society, the Promise Award from Susan G. Komen for the Cure, the Red Letter Award from the YMCA, and a citation by the Massachusetts Senate for her dedication to community service. So please join me in welcoming our expert for today, Dr. Renee Quarterman. Dr. Quarterman, thank you so much for being here with us.
Hi, Erin. Thanks for having me.
Oh my gosh. We are so grateful that you are sharing all of your knowledge and experience. And I will tell you, so thankful just to have you as part of our medical community. We rely so heavily on professionals like you. So happy to have you.
Thank you.
Of course, of course. So I know we got a lot of questions from our audience, which we'll get to. But let's start with just diving a little bit into genetics and genomics. So can you start off by just sharing a little bit about what are genes and genetic mutations? What is that?
Yeah, so the way I think about genes, I think about them like a part of a blueprint. So what I frequently tell my patients is that almost every cell in your body has DNA. Excuse me. And I consider that the blueprint that's going to tell that individual cell what to do for its entire life. And in that blueprint, there are about 25,000 instructions. And if there's an error in the instruction, that is a mutation. Not all mutations are bad. A mutation just means the code is abnormal or the code is wrong. A lot of mutations have no effect on the cell. They don't affect cell function at all. But some mutations can cause problems like certain diseases, including cancer. So those mutations we like to know about because in a lot of cases, we can enhance our screening, we can enhance our treatments, and certainly we can help promote public health because if someone knows they have a mutation, there's a chance that they could pass it down to their children or their other relatives may have the mutation as well.
Okay. So in terms of finding out about these mutations, genetic testing, I think it's something that many of us have heard about. Is it something that's been around for a while, or is that sort of a new technology that we have? How long has that been available to us?
It's been on the market for over 20 years. Probably in the late 90s, mid 90s is when it really started to get a lot of attention, kind of realizing the relevance of genetic testing and genetic mutations. But it didn't become as widespread as it is now until probably the mid 2000s. Things changed in the industry, allowing more companies to come in and offer genetic testing. And lots of people are just finding more mutations and the relevance of those mutations to diseases. So it's definitely become pretty commonplace for a lot of centers, particularly cancer centers, to be considering genetic mutations and genetic testing for their patients.
Okay. So I guess that brings up a good point, with new companies coming in and offering it and sort of changes in those early 2000s. How exactly is that done? Does it vary by company? And then I guess with those changes, has it improved the accuracy around genetic testing?
It has improved the accuracy because you've got more experts contributing to the data. Each company will offer its own type of panel of tests, but the mutations that they test for are the same. So it's not like if you went to company A, they were testing for a set of mutations that company B doesn't do. There's a finite number of mutations that we know about. And the information that we have is unified by science. And it's all in a database that everyone in the industry has access to. So
Got
from
it.
company to company, it really depends on how many genes your provider wants to test for and how comfortable they feel communicating with the representatives of that company. But patients
Got it.
shouldn't be concerned that one company does a better job or finds things that another company won't.
Okay, got it. I guess the equivalent of that would be, if a person has blood work they need to get done, they could go to any varying labs to get that drawn, but they're all looking, they all look for those same results. So I guess it would be
Exactly.
the equivalent of that. I'm really glad you pointed that out because maybe, some of our community members might think, they can only go to one organization for a particular test. So good to know.
Mhm, mhm. Yeah.
So in terms of different variants, we hear things like a pathogenic variant,
Mhm.
or someone might hear they have a variant of uncertain significance. What does that mean? And are those terms that may be concerning to someone?
Yeah, those are the more specific terms for a mutation, actually. And I like to use the term variant instead. So I'm glad you brought that up. So a variant means that the instruction is a variation of normal. And you can have a
Okay.
benign variant, meaning, okay, there's a change in the DNA, but it's not doing anything to the person's health. You could have a likely benign, you could have a likely pathogenic, and the likely pathogenic or the pathogenic means, okay, we know this mutation is linked to cancer. And then there's
Okay.
a variant of uncertain significance. So that means, okay, there's an abnormality here, there's an error in this instruction, but we don't know yet what it does. The data isn't showing us that it's linked to any type of cancer or disease. So it looks like it's not going to have any effect. It looks like it's probably going to be benign, but there's just not enough information yet. So
Okay.
when a testing company finds a variant of uncertain significance, they leave it in the database and they check every few months to see if anyone else in the industry, anyone else in the field has contributed any more patients with the same variant. And if they did, what
Okay.
were their outcomes? Did they have cancer or not? Most of those
Okay.
variants of uncertain significance end up being changed to benign or likely benign. But
Okay.
while they're variants of uncertain significance, or VUSs as we call them, they're not
Mhm.
actionable. So there's nothing we can do about them and nothing we should do about them.
Okay. I'm really glad you specified that because that was my question as well, which is okay, if they have this unknown, do they go back and check? Do they keep that data handy? So good to know
We
that
do.
they're keeping tabs, so to speak, if that is a result of a particular person.
Yeah, most companies like go back every 6 months, and I really appreciate the people in the companies that do that. But they must have to go through the database on every single variant that they
Yeah.
find. But they do it because it's important. And I've had a few patients where the company will call back a year later, 2 years later. Oh, that variant, it's benign. You can tell your patient.
Oh,
So it's
wow.
helpful.
Okay.
Mhm.
Yeah, very helpful. Very
Yeah,
helpful. Good.
it doesn't just get
So
forgotten.
good. Yeah. And right. None of us, think, want to feel forgotten. So it's good to know that it's also contributing to a greater cause, which is wonderful.
Yeah. Mhm.
So I guess going back to those genetic variations, genetic mutations, how often might that mutation be a cause of breast cancer? How often does that show up?
Well, there are about 80 or so genes that we know about whose mutations increase the risks for cancer. And
Okay.
out of those, about 10 of them, when they're mutated, increase the risk for breast cancer. And
Okay.
within those 10, some have a risk of up to 80%, some have a risk of 30, 40, 50%. So it's about
Okay.
9 or 10.
Okay.
Mhm.
Okay. That's good to know. And when someone has testing, just general, if they are doing genetic testing, if a person has been diagnosed with breast cancer, are they just tested for those 9 or 10 genetic mutations, or might a physician request sort of all of those mutations?
So this is where I think the practice of medicine comes in. I would recommend, and I do offer full panel testing for my patients. I don't just look for mutations related to breast cancer because sometimes you can find something else. I don't recommend that women just get tested for BRCA1, BRCA2. And most breast cancer specialists know that those aren't the only 2 mutations linked to breast cancer. So they're probably going to order at least that breast cancer panel. But I recommend a broader panel. Not everyone needs an 81 gene, but a 53, a 47, something like that to really get good coverage of I think the clinically relevant diseases is a good idea. Also, I think they can contribute to science, quite honestly, because if they have variants of uncertain significance, it can eventually turn a VUS into something benign and normal, which is helpful for everyone.
Right. Yeah, that's a really good point. So for those that have been diagnosed with breast cancer, how many women should be tested for a genetic mutation, or even those maybe that haven't been diagnosed, but maybe there's some family history? What is your recommendation in terms of how many should be getting tested or thinking about getting tested?
So it's 2 different buckets. For breast cancer, the American Society of Breast Surgeons, which is the professional group I'm most active with, is really recommending that every woman be considered and offered genetic testing. And that's because we now know that out of all women diagnosed with breast cancer, no matter what age, about 10% of them have a mutation that's related to the disease. That's a lot of women. So if you know that, again, it can enhance your treatment. It can certainly give the woman more information so she can be empowered to be proactive for her own health. And it can help the public health because her relatives, can be tested if they want to. So that's one bucket. I do discuss genetic testing with all of my women who are diagnosed with breast cancer. A lot of them, I'll say, listen, you're entitled to this, but looking at your lack of family history and your age at diagnosis, it's very unlikely that you have a mutation. But if you'd like to get tested, let's talk about it. And most of them do it and feel a lot better having done it. So that's one bucket. And then the other bucket is the people who don't have a personal history of breast cancer, but they've got a family history suggesting that they have a mutation. So if there are first, second, or third degree relatives who had breast cancer under 50, people who had breast cancer in the family and ovarian cancer, pancreatic cancer, prostate cancer, there are a lot of different combinations. So it's very important for a woman to know her family history and to make sure that her provider knows it too.
Yeah. Well, and I'm glad you called out those other diagnoses that may be present in a family's history, because, just sort of thinking about outside of breast cancer, what are these other family features that a person should be aware of that may indicate maybe I should get genetic testing? So are there any other health conditions outside of the diagnoses that you just mentioned that may, trigger a person to be like, okay, maybe I need to have this conversation?
Well, I'm thinking like ovarian cancer, like a constellation: ovarian, breast, pancreas, prostate. Those are the main kind of diseases that make you think about the mutations that are related to breast cancer. But if there's a family history of a lot of prostate cancer, there's a mutation related to that in a lot of cases. Thyroid cancers, certainly colon cancers, stomach, small intestine. So it's not just breast cancer. And it's not just breast cancer on the mom side of the family. I think it's really important to get as much of your family tree information as possible. And then you may not need testing, but you should go see a genetic counselor for them to look and kind of decide if you meet any kind of pattern where you should be tested.
Yeah, that's wonderful. Yeah. And just quick side note, you mentioned genetic counselor. if someone was interested in connecting with a genetic counselor, is that someone that their medical oncologist would be able to refer them to,
They're
or someone
medical
that should be part of their
oncologists.
practice?
Yeah, they're surgical oncologists. We have those connections.
Okay.
Primary care providers can find them as well. Usually, genetic counselors are associated with hospital systems.
Okay.
And if your primary or your GYN doesn't know of any in the community, they probably have connection to a genetic testing company. And
Okay.
those companies also have genetic counselors on staff. They're not biased. It's all the same science.
Mhm.
And they can also offer kind of remote consultations.
Okay.
And then there is an organization that I belong to where when we hear about people needing genetic counseling in the Dominican Republic or in Florida in some place or California someplace, they can't find a counselor, we can kind of get online together and say, well, I'm over here, I'm over there, and we can help each other out. So you can find
Oh, wonderful. Yeah, we can find them. Okay, good.
Yeah.
So lots of different avenues someone can go down to find that counselor. That's good to know.
Right. Yeah.
So, in terms of why it's important to even be aware of genetic mutations, why it's important to consider this sort of testing, why is that helpful if a person has been diagnosed with breast cancer?
It's helpful for a few reasons. One, if a woman has what looks like a small cancer and maybe she's thinking about just doing a lumpectomy and radiation and moving on with treatment from there, if we find out that she has a mutation that's related to breast cancer, we might say, well, listen, your risk of this cancer coming back in your lifetime is as high as 85%. So maybe you don't want to just do a lumpectomy at that point. Maybe you actually want to have bilateral mastectomies so that you really minimize the risk that you're going to go through this again. Well, that's one reason to do the testing. Another thing is that if that same woman has a mutation, but she still wants to just do a lumpectomy, that's fine. But now, knowing that, we're going to tell her, well, we need to screen you for breast cancer twice a year, not just once a year. So you're not going to just do mammograms. You're going to alternate mammograms with MRI or mammogram with ultrasound every 6 months. So that's another reason it's helpful. Another reason is that there are some mutation-specific breast cancer therapies, not many, but there are some. And so if a woman has a mutation, that could enhance her treatment and improve her outcomes. And then finally, if she's got a mutation and she's got children or siblings or cousins, then those people can be advised to get tested, which can help their health as well.
So many good reasons for sure to really consider that. We had a great question in the chat from Lynn, just going back to what you said earlier about sort of companies going back and rechecking their file. Is this information that someone in the public might be able to view a person's policy on, or how would, if it were me and I had one of those unspecified variants, how would I be able to go back and know how often they're testing? Is it something that I should just ask my contact person at that testing company? Are you aware of how
I
that
don't
might
know
go?
if it's easy to get that directly from the testing company to the lay public.
Yeah.
I know that the reps that I work with at the genetic testing companies, they tell me we check every 6 months. I think that's standard.
Okay.
If you want to specifically know and you have your genetic testing report, I think you could call and say, okay, here's my ID, so they know you're a client, and then you ask them. You can ask them if there have been any updates in your variant, in your VUS. But really, it's the responsibility of the provider that ordered the test. So if there's a change in that variant, the company is going to talk to the ordering provider, and it's that ordering provider's responsibility to tell you.
Okay.
That's how it happens.
Got it. Okay, good.
So if Lynn hasn't heard back, and hasn't heard anything, maybe the first thing to do is go to her provider and see if they've found anything out. They might need to be kind of tickled to go check.
Always worth asking the question, right?
Yeah, unfortunately, that's not easily accessible to the lay public to get that.
Yeah, good. But that's a great question and good advice for sure.
Yeah.
So in sort of breaking out, different groups of women and how often genetic mutations happen, is there a difference with the rates of mutations that may occur in different communities, different backgrounds of women? Does that play a role at all?
We know for sure that women of Ashkenazi Jewish descent that line through Eastern Europe are more likely to have mutations, the BRCA1 and BRCA2 mutations. It's kind of what we call a founder mutation, meaning that there was something about that group they were able to kind of isolate and stay together and not have a lot of mixing of other DNA, allowing this mutation to kind of flourish and be not dominant, but certainly be prominent compared to other groups.
Okay.
So we always want to find out if a woman is of Ashkenazi Jewish descent, because that does trigger, consideration for testing.
Got it.
And in terms of other groups at this point, it doesn't appear that other groups are at increased risks for certain types of mutations. We do know, however, that there isn't a lot of representation in these groups, and we're trying very hard to bring in more women from all ethnicities, so we really get a picture of who's more likely to have what type of mutation.
Yeah.
Interestingly, I'll also say that there is something called epigenetics, and I don't want to get too far into that, but you have your DNA, you're born with it, it doesn't change, but we do know that there are things that happen to it after you're born that will affect it going forward. So stress or inflammation or things in the environment can change how your genes are read and how they function, creating in some situations a certain type of mutation.
Okay. And I guess in that instance, again, without getting too off course here, but in that instance might be something that could affect future generations. Is that something that, down the line might be consideration?
It could. And we don't have testing for those things yet, but by and large, the majority of breast cancers in this country are caused by environmental changes. And so I wonder, and we know a lot about a lot of those changes, and I wonder if they're changing kind of they're doing some epigenetic changes, or certainly affecting those cells to make them more prone to mutate and turn into cancer. It's fascinating.
It's super fascinating. Genes, I think, in general are just so interesting.
It's amazing.
Yeah, it is amazing. Okay, so not get it, because I could go totally off on a tangent, but let's keep on track here. So we talked about different groups of women and, different rates of mutations. Different groups of women, are there different rates or how often a person may receive genetic testing based on their ethnicity, their background? Is that a thing?
It kind of is. So 2013 was a turning point in the world of genetic testing, because before 2013, we were really only doing single site or two site testing, looking for BRCA1, BRCA2, and that's pretty much it. Okay. And now we know that it's really important for women and men to test for a broad panel. So after 2013, that's when we started to offer more broader panels for testing. So I always ask, if somebody says, I got tested. Well, when did you get tested? 2008. Okay, we need to retest you. So that's a change. But the testing doesn't change so quickly. So, if you were tested 5 years ago, I wouldn't test you again. Now, having said that, if you've suddenly got this new strange family cancer history, and I'm thinking, I wonder if this mutation is there, I might ask you to give me your panel so I look and make sure you were tested for that gene. But they don't discover genes so quickly, that if you were tested last year, there's something new since then. But I'll say this, I always tell my patients, keep a copy of your report and give a copy to your children.
So great advice.
Everybody knows what genes were tested for, because down the line, we might find something else. So 20 years from now, people could be talking about the blah, blah gene, and every provider knows about it. So if you take your report in and your provider can say, oh, you weren't tested for blah, blah, we should test you.
Mm-hmm. Mm-hmm. Wow, sound advice for sure. So, so is there a year cutoff that someone may consider getting genetic testing again, more updated? Is it that 2008 year? Do you have a general?
2013.
2013. Okay.
2013.
Okay.
Mm-hmm.
Got it.
Yeah.
Wonderful. Thank you for that. So, okay, so we've covered a lot about the upsides of genetic testing, right? All of the good information that we can learn, our families can learn. Are there downsides to genetic testing?
So, one downside that I've not heard of, but we're always warned about it, is possibly finding out that your relatives are not who you think they are. So, if you're doing genetic testing and you're trying to figure out, did this come from mom or did this come from dad? Why do you have this gene and you don't have this gene? It doesn't make sense. We are finding, your parents aren't your parents, or that's really not your brother, or your cousin's actually your sister. I mean, that's possible by doing all of this genetic testing, really finding out who's related to whom.
Okay.
There has been concern that maybe if you have a mutation that's considered a pre-existing condition, and so you're not going to be able to get health insurance or get a certain kind of job. And there is a law, for short, it's GINA, G-I-N-A. It's a federal law, which says that health insurance and employers cannot make any decision regarding a person based on their genetic testing information, meaning that those two entities cannot consider a mutation a pre-existing condition. Wow. So if you have a mutation and then you get some new health insurance, they can't hold that against you. I don't even know if they could even ask if you have one.
That was going to be my question is that asking for that information even appropriate from the company? I don't know. So I'm glad you mentioned that.
As far as I know, I think the only thing a health insurance company can ask is, do you smoke? And I don't even know if they're allowed to do that. So the genetic information is really as protected as it can be. And I think it's a little more protected than other health records, because at least in the state of Delaware where I am, if a doctor contacts me and says, well, Dr. Quarterman, can we get Erin's genetic testing report? I will not just send it to them. Right. If they say, will you send us her last note? Sure, here you go. But we have to get the patient's written permission to share genetic testing. So it is not easily distributed. Now that's different from state to state, but I think that's the general.
It's as protected as can be.
Yeah. So that concern about your information being held against you, it can't be. Now, I will add that that's not necessarily the same thing for life insurance or disability insurance. I haven't heard of, and I've asked experts about this, any cases, at least in Delaware, of those companies denying coverage or not allowing you to enhance your benefits because you have a mutation.
Okay.
I suppose they could, but again, how would they get that information?
Right.
Unless we volunteer it, I don't know how they would get it.
Right. Yeah. Okay. Good. Really great things to consider.
Yeah. And one more downside, because this happened to me last week. A gentleman came in and we were talking about genetic testing. His sister has a mutation. So we were talking about him getting tested, and I told him everything, and he stared off and he said, I just think I might worry more if I know I have a mutation.
Right.
And so that's a real possibility for some people too. You have to think, well, how would you feel if you had a mutation? How would you feel if you had a variant of uncertain significance?
Right.
You have breast cancer. I'm testing you, but I'm not just testing you for mutations related to breast cancer. What if we find the mutation that increases your risk for colon cancer? How are you going to feel about that?
Yeah.
Some women say, well, I don't want to know because I'd feel guilty thinking that I might pass that on to my children. So I'd rather them test themselves. I don't want to know.
Yeah. Wow. And I think a lot of us, we might overlook just sort of that emotional impact having that type of information may make on us. But I mean, it's a really, really great point for sure.
Yeah, because a lot of women, if or men, you have a mutation, that's more responsibility on you.
Right.
You know,
Absolutely.
if you went so far as to be proactive about your health and get tested, then you're probably going to think, well, I got to do the screening. Well, I got to do the prophylactic thing. I got to do the
Right.
medicine. It's like,
Right.
do you want all that? Maybe
Right.
ignorance is bliss for some people.
Yeah, sometimes it is. So yeah, definitely taking that into the consideration when you make that decision is really important. I'm glad you mentioned that.
Yeah. Mm-hmm.
Okay, let's talk a little bit about one of the other things that I know that we've heard of and sort of has come up in this genetic conversation is about circulating DNA,
Mm-hmm.
circulating tumor DNA.
Mm-hmm.
Can you explain a little bit about what that is and how it's used to treat breast cancer or just in, the overall breast cancer conversation?
Yeah, so circulating tumor DNA, or I think some people call it a liquid biopsy because it's a
Mhm.
blood test, started out in, I think it might have been colon cancer, it wasn't
Okay.
breast cancer. But the idea is that cancer cells leave molecular disease fragments kind of that break off and circulate through the body. And if there's a way to test for that, you can measure the amount of those tumor fragments, which could indicate that disease has come back or disease has persisted.
Okay.
So it is new in breast cancer, and I'm sure we're going to be using it more and more.
Okay.
For breast cancer, you have to look at the main tumor
Hmm.
and you basically get its profile, like a fingerprint of the tumor.
Okay.
And then the company is able to make a specific test for you based on that cancer to
Wow.
then evaluate your blood every 6 months, every year, whatever your doctor wants, to see if you've got molecular levels or just levels of that residual disease in your blood.
Present.
So
Yeah.
that's circulating tumor DNA. And what we're finding with breast cancer is that it is more sensitive than things like CA15-3 and other molecular markers which are traditionally used, which we
Okay.
don't use very much because they're not necessarily very sensitive or specific. We're like,
Okay.
what are we going to do with this? What does it really mean?
Right.
But the circulating tumor DNA seems to be more accurate and more
Wow.
clinically relevant. So
Okay.
it can find, and studies have shown that when those levels go up, that seems to happen before the disease becomes clinically relevant,
Wow.
before we see a metastasis in another part of the body. So the idea is if you see those numbers go up, your oncologist can start treating you before the disease
Early.
becomes clinically apparent,
Hmm.
which would be expected to, improve your overall health and your outcome.
Right, right, right. Is that something that is automatically done across the board? Is that something that a patient needs to request of their oncologist?
It is not automatically done across the board, and
Okay.
not every oncologist is going to do it. It is
Okay.
very, very, very new.
Okay.
So new that a lot of insurance companies are not even covering it. I
Oh,
think
wow.
that Medicare has now approved coverage of that type of test for one company
Okay.
um, for stage 2 breast cancer, so not even early breast cancer.
Okay.
And I'll say I wouldn't recommend a woman going through all of this for an early stage, kind of a small node negative breast cancer, strongly estrogen, progesterone receptor positive. It's
Yeah.
probably not going to help that. Uh,
Okay.
but there are, triple negatives and HER2 new and larger tumors and node positive disease.
Yeah.
I think those are the appropriate groups to start it.
Okay.
But again, it's so new that it's really teaching all of us oncologists about the value and bringing out the data to convince us that it's relevant.
Wow.
And I think honestly, the more patients know about it, they
Yeah.
can ask their doctors, and then the doctors can do their own research and decide if it's right for them or not.
Okay. Okay. Really good to know. And I'm glad that you sort of called out, particular types of diagnoses that may be appropriate, that may not. So, we know who it may be good for, but hopefully more to come on that, with it being so new. It sounds really, really promising.
It's really, I mean, we're doing more and more personalized medicine. If that's not personalized medicine, I don't know what is.
Right. It's the definition of it, frankly.
Yeah, it is.
Wow, amazing. Yeah. Amazing. Okay. So we've covered a lot. I want to jump into some of these really great questions we've received from our community leading up to today. So I'm glad you mentioned we did get a question about sort of the background of being Ashkenazi Jew. So I'm glad that you sort of clarified why that individual with that background may be prompted to have some genetic testing.
Okay.
You also mentioned, someone had posed the question, someone that had both genetic and genomic, is that ever a reason to do it again? Or with genomic, can you ask for updated lists? So I feel like we covered that, especially with that 2013 sort of time frame to think of. Anything else to add in terms of why someone would want to have that testing done again?
If it really depends on if your provider is concerned about a mutation in a gene that you weren't already tested for.
Okay.
Really.
Okay.
Yeah.
Okay.
And I guess, go ahead.
No, I was going to say just another reason to keep those results nearby and have them handy to refer back to.
All of my patients, whatever test they get, biopsy, surgery, genetic testing, blood work, I always give them a copy. And I strongly recommend for every patient, whatever doctor's visit you go to, ask for a copy of your records. Absolutely. Leave it in a file so you always have it. It's good for you, and going down the line with a new doctor, they will love you for it.
I know it.
We would rather have too much information from your basement than like none. So keep everything.
Yep.
That question though, Aaron also asked about genomics, and I'll say if people aren't sure, there is a difference between genomic and genetic. So genomic is looking at the gene profile of something. And for breast cancer, genomics are looking at the gene profile of cancer. And so there are some companies that do that, and that information translates into a score to tell you what's the likelihood that this disease is going to come back or not, what's the benefit of chemotherapy. So I think that in terms of that testing, they are probably always going to be looking to refine it and change it. Will there be a possibility in the future where they'll go back and retest all of their specimens? I don't know. I don't see how that's even possible, because they do millions, well, maybe not millions, but tens of thousands at least a year.
Yeah.
So that's a good question about that. Yeah, I don't know if they would.
Hard to tell. Yeah, hard to tell.
Yeah.
Okay. Another question we received, a little more specific. So this individual said, I tested positive for the RAD51 pathogenic gene. My sister was diagnosed with breast cancer at 42, did not receive genetic testing. What are the surgical and treatment options for this gene? How does it affect an African-American woman at 40, diagnosed at 39, ER 30%, PR negative, HER2 negative, stage 2, grade 3 breast cancer? Can you speak a little bit about that?
This woman has breast cancer and she has the mutation? Or her sister had that cancer and this patient just has this?
She was also diagnosed. Sister was diagnosed at 42, 16 years ago, did not receive genetic testing. She did, and she was positive for the RAD51 gene. She was diagnosed at 39.
Okay. So first of all, I would make sure that she got tested for an actual panel.
Okay.
The RAD51 genes, there are two that are linked. There are two that, when mutated, increase the risk of certain cancers, and that's RAD51C and D. So they are significantly linked to breast and ovarian cancer. So they can increase breast cancer risk to like 20 to 50%. They can increase ovarian cancer risk to like 15 to 30%. And so when your risk for breast cancer is that high, we definitely recommend semi-annual screening, getting screened every 6 months, alternating mammogram with MRI. And if you've got a diagnosis of breast cancer, it would be supported to consider bilateral both side mastectomies to minimize the
Okay.
chance that this is going to happen to you again.
Okay.
If she's 39 and she didn't have a mutation and she chose to have just a lumpectomy, she would need to be screened twice a year. So with a
Okay.
mutation, she would need to be screened twice a year. But she should
Right.
also, once her breast cancer treatment is complete, see someone about having her tubes and ovaries removed. And then
Got it.
certainly her relatives, first, second, third degree relatives should be tested. If she has children who are not adults yet, again, put these reports in their folder. And when they hit 18, say, here, this is what this means. Let's talk to a doctor about when it's appropriate for you to get tested at what age.
Mm-hmm. Mm-hmm. Love that.
Yeah.
Family communication, so important with sharing for sure.
Yeah.
Okay, just quickly, another question. Is there a test done for HER positive, ER/PR negative for prognosis or treatment? For example, the OncoDX is it always ordered? Pardon me. So is there a test for someone that's HER positive, ER/PR negative for prognosis or treatment?
At this point, no, there isn't, unfortunately. The company that does the Oncotype, they are probably looking into it, but they don't have something right now. But I will say for HER2 positive disease, it's very exciting that we've just got more treatments directed at that protein. And so if a woman can get treated up front, and then she can get treated kind of later with different medications. But in terms of profiling and prediction of what the disease is going to do, as far as I know at this point, no, there isn't any test for that.
Okay. Thank you. Pardon me. And I guess one more question to just sort of wrap up, if you have time, just sort of, I think this is a good wrap up for thinking of generations ahead. We've received a question. My twin sisters and myself have all been diagnosed with breast cancer. 2 of us are going through cancer for the second time. Could genetics play a part in our cancer coming back? And what advice would you recommend for our daughters?
So definitely, it sounds like genetic testing should be done to not just one woman who had breast cancer, but to all of them, because mutations that run in the family, not every relative has it. You would expect twin sisters to have the exact same DNA. If they're identical twins, then it might be appropriate to just test one, but I'd probably test the other if she were my patient anyway.
Yeah.
So that's the first thing, is make sure genetic testing's been done. And for the daughters, or anyone who hasn't been affected by breast cancer, they really should get their breast cancer risk calculated. So that's something that providers like myself do. There are standard calculators that we use. We get family history, look at first, second, third degree relatives, history of breast cancer, how old were you, ovarian cancer, how dense are your breasts, how old were you with your first period, a lot of hormone exposure questions, and that gets put together into a calculation, and we can say, okay, in black and white, your lifetime breast cancer risk is this. If it's 20% or greater, then it goes back to that screening twice a year, alternating mammogram with MRI. And so if women are 25 years or older, that kind of testing and evaluation should be done. So I would recommend that as well. And if the children are too young for that yet, then she can take it upon herself to write down all of the details for those children to use when they are old enough to kind of advocate for their own health care. But what doctors are going to want to know is who had cancer, what type of cancer was it, and how old were they when diagnosed. If you know the specifics of the cancer, not just my aunt had breast cancer at 30, but my aunt had triple negative breast cancer at 30. As much detail as
Right.
that, as you can, that would be helpful too. Or my grandmother
Okay.
had DCIS at 50. That's different from her having breast cancer at 50. So those kinds of details
Okay.
are really informative.
Are really important. Okay. And for someone, just real quickly, for the daughters per se, this question about risk score, is it something that they could just talk to their GYN about? Is that sort of a first conversation, or do they need to go to a specialized medical professional? Who might they be able to assess that score with?
It's really best to see somebody who does this all the time. Some GYNs
Okay.
do, some don't.
Hmm.
I mean, I'm a breast surgeon, so I do this for all of my patients.
Yeah.
But not even every breast surgeon does it. It really depends on the practice. And so
Okay.
it's really kind of calling and finding out who can do it.
Okay.
Yeah.
Wonderful.
Mm-hmm.
Oh, Dr. Quarterman, thank you. That was
You're
amazing. That
welcome. This
was,
was fun.
oh, this was great.
I hope
We
it was
packed in
helpful.
a ton of information. I think it was.
Good.
Hopefully, that was helpful for those that have hopped on. We so appreciate you being part of our Unite for Her network and being a provider among our community. So we're so grateful for you and just shedding a little bit of light, answering some questions about a world that's super interesting, but also super confusing for some of us. So we're so grateful for you.
Thank you. I'm really happy to be part of the community, and I'm happy to answer any questions, even offline. You can email me if people have any questions.
Wonderful. Is there a particular email address that we can put in the chat for those that can reach out to you?
Yeah, so I invite people to look at my website, DelawareBreastCare.com. That's all one word. I work very hard to put a lot of educational material up there. And
Good.
then if you have any questions, you can email me at info@DelawareBreastCare.com.
Perfect.
I also have an
DelawareBreastCare.com is
Instagram.
that website.
I have an Instagram and I have a Facebook. There's not a lot of information.
Great.
It's just very entertaining.
Hey, that's okay. At least we know how to stay connected with you. So we appreciate that.
I have
Perfect. So we'll put
Quarterman
that
and I have
website in
Delaware
the chat.
Yeah, perfect.
Excellent. Lots of ways. Wonderful. Wonderful. Well, thank you again. And our community, big thanks in the chat for wonderful presentation, wonderful information shared. So thanks for spending your afternoon with us.
Bye, everybody.